just first say thank you for coming to the CAPS Implementation Science and Health Systems Core Town Hall. We're really excited to have two amazing speakers today talking about social and behavioral science highlights from AIDS 2022. I personally didn't get to go, so I'm really excited to hear what they're going to bring back to us. So we have two speakers. The first is Dr. Judith Auerbach. She's a sociologist and professor of medicine at UCSF, an independent scientist and also a policy consultant. And she's served in multiple leadership positions in government and at non-governmental agencies. Those would include the NIH Office of AIDS Research, AMFAR, the SF AIDS Foundation, to name a few. She's also served on a number of boards and advisory groups, including groups like PEPFAR and the Governing Council of IAS. So most importantly, she is a tireless advocate for inclusion and recognition of the role of social science research in the HIV response. So we're excited to invite you here today, Judy. And Judy will be joined by Robert Williams, who's been working at CAPS for over 15 years, including supervising and coordinating NIH-funded research to adapt and evaluate the Empowerment Project with young African-American MSM in Dallas. He also has a 20-plus year history working in CBOs focused on African-American MSM, including the Sexual Minority Alliance of Alameda County and Oakland on the board of directors for the AIDS Project of the East Bay, and served on numerous community advisory boards locally and nationally. And given his expertise, he was also invited to advise on the national HIV/AIDS strategy around issues with Black MSM and HIV prevention. So with that, I am going to just go ahead and share these slides and ask Judy to take it away.
Okay, well, thanks very much, Sherry, and thanks to you and Rochelle for organizing this, and Robert to be my partner in crime here. I'm going to present some select highlights from AIDS 2022 from my own point of view and from the lens of what I thought would be most of interest to this particular audience, given our focus at CAPS and DPS, and specifically with the implementation science and health systems core. And Robert is going to also provide some of his impressions as a first-time attendee. I guess I would start by saying my understanding is there were about 6,000 people in person at the conference in Montreal, which is much smaller than these things usually are. I think most of you either have been to them or are aware they're normally populated by about 15 to 20,000 individuals. So it was quite reduced, and it was a hybrid conference with in-person and virtual presentations, which actually meant there were fewer sessions. There were fewer in-person sessions because they had to juggle a time schedule that could work in various time zones. So as I was perusing the program and deciding what to attend, I would see there were only 2 abstract-driven sessions a day on, the social science track or implementation science track. But nevertheless, what I've done is cull from the things I attended and a few sessions I did not attend, but I think are of interest. And my purpose here is not to provide you a comprehensive review from track D and track E, which are the most relevant tracks for us, but to highlight some themes that cut across sessions in both of these tracks and even other tracks that I think are of greatest interest. And what I've done on the slides, as you'll see, is put in the session numbers, because as of a day or two ago, the entire the International AIDS Conference program is now available to anyone to peruse. So you can see the abstracts, you can see the e-posters and everything else, even if you were not registered for the conference. So they've just opened it up to the public. And what I'm trying to do is give you some shortcuts to identify some sessions and presenters you may be interested in pursuing. But this is also my way of saying, don't interrogate me about the projects, because I don't know the details of every single one of them. I certainly don't remember all their findings. It's just to give you a taste. So with that, I'd like to begin. Next slide, please, Sherry. And thanks, Sherry, for forwarding my slides. Before the main conference began, there were a series of meetings and pre-conferences. And one I attended and wanted to be sure to mention to you for a couple of reasons was the annual meeting of PEPFAR, the President's Emergency Plan for AIDS Relief, which I think everyone knows is our U.S. government global AIDS program. And this annual meeting is chiefly attended by the program implementers across the world and the PEPFAR and OGAC staff and the Office of Global AIDS Coordinator staff and others. But I was invited in my capacity as a member of the PEPFAR Scientific Advisory Board and was really quite pleased to be able to attend. And what I wanted to highlight was first, the fact that there's a new leader in PEPFAR, you may have heard this by now, who is ambassador at the ambassador rank for this job, John Nkengasong, who comes most recently from the Africa CDC, which he helped co-found. And he is a dual Cameroonian and American citizen, which is why he was able to take this job. So this was also our main introduction, the global community's introduction to the new leader of PEPFAR. And Ambassador Nkengasong began by presenting some of the key accomplishments in just the last quarter of PEPFAR, and also to talk about the pivoting of PEPFAR during COVID and what was able to be achieved under some very challenging circumstances. So I put some of these on the slide here. I don't need to read them, but you can see. And I think, what's particularly striking is the increases in numbers of people who are initiated with ART, the reductions in babies born with HIV, and then specifically during COVID, the increases in multi-month dispensing of ART, which I think will be a post-COVID phenomenon we're all going to be thinking about, and the increase in use in self-tests, as well as initiation of people on PrEP. Next slide. But the other key thing he presented, which is of real great importance and interest to us, I think, is a new vision for PEPFAR. And the title of the slides, as you'll see, was kind of a mistake. It's supposed to be reimagining, not reimaging. I clarified that with PEPFAR. Beginning with the purpose statement for his vision, which is to reimagine PEPFAR, to put it on the path to ending the HIV pandemic as a public health threat by 2030 and sustainably strengthening public health systems. And this vision is based on 5 pillars, as you can see here, strategic pillars that are health equity for priority populations, sustainability, health systems and security, partnerships, and science. And these pillars are supported by and made possible through what he calls enablers, innovation, leading with data, and community leadership that run across them. Most important one here for us, I think, is the science pillar. And what is so striking about it is when Ambassador Nkengasong introduced the science pillar and the text around the science pillar, what you see is an emphasis on behavioral, social, and implementation science, not clinical biomedical science and epidemiologic science. So he has made it his mission to try to better integrate and enhance and support the relevant behavioral, social, and implementation science for PEPFAR. And just an FYI, I've begun some conversations with some folk on his staff about how we all can be helpful in that regard. So turning from that to the actual main conference, as I say, I've identified what I think were what I found to be some key topics and themes cutting across the program, particularly in Track D, which is the social and behavioral science track, and Track E, which is the implementation science track. So this isn't comprehensive. There are a lot of topics not included. One that will jump out is I did not actually attend much and think much about long-acting injectables. I think Robert may say something about that in his remarks, but that's something I think everybody's following anyway. So here are the key areas that I'm going to cover, hopefully in a little bit of detail, enough so that you can search the program if you're interested and find more of the detailed science. Stigma, community-centered approaches, implementation approaches, integrative services, the impact of COVID-19 on HIV services, and global health equity. And then I'll mention at the end a few others of interest. So with regard to stigma, the first key topic and theme, one thing that occurred at the conference was the launch of 2 special issues. You may have seen them before the conference, but they were officially launched there that are focused on stigma. One, the Journal of the International AIDS Society on Getting to Know the Heart of Stigma. That was presented at a whole pre-conference. And the other, the American Journal of Public Health on addressing intersectional stigma and discrimination to improve HIV-related outcomes. And so I'm not going to summarize those launch events because they basically were presenting the articles in the journals, which you can go find and read. But very much related and with a lot of overlap and participation was a session in Track D that was abstract driven on stigma interventions, improving health and wellness for people living with HIV and key populations. And in that session, Carmen Logie from Toronto talked about experiences of stigma among youth sexual violence survivors in refugee settlement, and found that youth had anticipated stigma for seeking HIV services related to shame, blame, and mistreatment from sexual violence. And that was research in Uganda. Rogerio Pinto, using critical dialogue methods and illustrations, found that initial homophobic and sexist attitudes among formerly incarcerated heterosexual men could be actually mitigated through extended conversations. That's research in the US. Our own Amy Conroy, who I don't think is here, presented her research and found the impacts of HIV stigma appear to be moderated by relationship dynamics among couples, dynamics including communication styles and sexual satisfaction in couples in Malawi. I think she's presented that at a town hall here before. And then Innocent Arenawati presented research among men with HIV that found that a significant relationship existed between food insecurity and HIV stigma that was moderated by social support. And that was research in rural Uganda. At the track D, the behavioral and social science track late breaker session, there was a presentation by Thomas Carpino that was an analysis of data from the America Men's Internet Survey that showed that adjusting for age, education, race, HIV status, and region, sexual and gender minority men who had an STI diagnosis were twice as likely to have experienced general community stigma. So those were some specific presentations there. So cutting across all those sessions, could you go back, Sherry? Cutting across the sessions on stigma, there were some obvious common themes. And firstly, the need to understand and address the operations of stigma through an intersectional and syndemics lens. Secondly, the need to include resilience and strength-based and assets approaches, not just the pathologizing approaches. The need to improve frameworks, methods, and measures of stigma, particularly intersectional stigma, and the need to acknowledge social structural processes and power relations that produce and reproduce and influence stigma and mitigation. Okay, second theme, next, please. What I would just broadly refer to as community-centered approaches. There were a lot of sessions, I'm probably not capturing them all, that did talk about how to center community in the HIV research and broader response. In track D, an oral abstract session on through the lens of community, there were a number of presentations, one from Julius Casillo on MTCT, preventing mother-to-child transmission, which was shown to significantly decrease when all stakeholders, including health workers and mentor mothers, are adequately trained to support ART adherence. That was in Kenya. Jenny Pearson used prospective data for a 10-year period, found that high social cohesion and access to sex work specific led services were protective of recent physical and sexual violence in community-based cohort of female sex workers in Vancouver, Canada. Marie Lichtenberg presented a total control of the epidemic TCE program that involved these TCE trios and buddies who supported disclosure and treatment adherence, which was shown to be effective in reaching over 90% adherence and 99% case finding targets in Zambia. And Armstrong Mukundane talked about research following and that showed that following an HIV orientation program, cultural leaders, including kingdom ministers and clan heads, county chiefs, and youth leaders, led to organized fireplace discussions with youth that appeared to result in reduced teen pregnancies and increased uptake of HIV testing services in the region compared with other regions. That was Buganda Kingdom and Uganda. There was a symposium called the Gold Standard Measuring Quality Healthcare for People Living with and Affected by HIV that also emphasized community-led approaches. This session highlighted innovative ways in which communities can be effectively engaged to lead in developing robust data systems for monitoring and measurement of healthcare, effectively rethinking whose priorities and indicators are paramount. And chief among this was a presentation by Solange Baptiste from the International Treatment Preparedness Coalition, ITPC, which discussed community-led monitoring, CLM, as a strategy for accountability and measuring health intervention impact. In the CLM model, communities take the lead on routine monitoring, collecting even, and routine monitoring of issues of importance to them. thereby surfacing data gaps that might otherwise not be observable. And she outlined the ITCP model and methodology, whose components are education, and these are each defined in detail: education, evidence, engagement, and advocacy. But she described a project in Sierra Leone in which community members on their own observed 5 healthcare facilities and monitored how many people with HIV experienced treatment failure during COVID-19, and found that these data were otherwise not being collected. Exposing that gap led to the National AIDS Control Program in Sierra Leone to include this indicator, people who, with HIV who are experiencing treatment failure, as a new national indicator. And then other examples were also presented of the CLM from South Africa, from Nepal, and Uganda. Those are in e-posters. There was a prime session, so these are the sessions that there are no competing sessions when they're occurring, on strengthening health systems, in which presenters showcased successful approaches for strengthening health systems through community engagement and leadership. And chief among these, and this program has been presented numerous times at other conferences and was throughout this conference, and that is the Key Population-Led Health Services, or the KPLHS approach implemented in Thailand. And it's a model, and this was presented as a model for shifting from community involvement to community leadership, and in their case included the first sexual health and well-being clinic for transgender people in the country. And the argument that the presenter, whose surname I'm going to butcher, but it's Rina Janamnuyusuk, argued that this KPLHS model can be used to sustain health systems by achieving the following implementation outcomes: quality, availability, acceptability, and accessibility. Again, each of these is defined. And it was important that she noted that the long-term multi-level implementation strategies were adopted to integrate the KPLHS model into the national healthcare systems to improve its sustainability. And that integration is really what was key here. And so this included training and certification of service providers, the use of manuals and quality standards for HIV service providers, champions from community-based organization leadership, coalition for collaboration and joint advocacy, and high-level policy and advocacy dialogues with various stakeholders. Moving along, there was a symposium on inclusion means involvement, and that session included our Assistant Secretary for Health, Admiral Rachel Levine, and Steph Baral, who many of you know from Johns Hopkins, and other speakers who reiterated many of the issues that we at CAPS and DPH have really been focusing on and are very familiar to us, including the importance of integrating community-based participatory research methods in all stages of HIV research, particularly as it relates to stigma reduction and vulnerable populations, integrating lived experience of communities in research from protocol development to data sharing, addressing power dynamics in the research establishment environment, revamping or flipping funding structures. So, for example, to provide the primary funding to the community lead and to have the academics as sub-awardees, and recognition and support for community members' research contributions through co-creation processes, and so on. And then finally, track D had an abstract-driven session in which there were 3 presentations that explored how to use a community-first approach to better engage young people from the community in HIV prevention and care initiatives. And these were in the US with young Black, gay, and other men who have sex with men, in Uganda with youth with HIV, and in Zambia with young key populations. Next. Okay, a third key theme, and I actually will hope that you'll keep me on time here, by the way. A third key theme is what I would generally call implementation approaches. One key session was a symposium on how does implementation science affect HIV policy and vice versa. This was co-sponsored by the Journal of the International AIDS Society, and the panelists were people from NIMH, Diane Rausch, who I think you all know, Jeff Garnett from the Bill and Melinda Gates Foundation, Anjali Agrakar from PEPFAR, she was the acting administrator before we got the new ambassador, and Yazdan Paha from the French ANRS, as well as Marlene Brass, who's the managing editor of the JIAS, the Journal of the International AIDS Society, and it was moderated by Ken Mayer, who many of you know. And the point here was to really talk about, I guess there were sort of three key issues to the panelists. What did they think were funding priorities in implementation science? It was the first, and they all iterated what they were from NIMH, Gates Foundation, and PEPFAR point of view. What was particularly interesting to me was the Gates Foundation point of view. Jeff Garnett presented, he said self-testing, health prevention literacy, overcoming barriers to stigma, making services available to all in need are important to the foundation, which focuses on prevention, and its implementation science kind of falls across their strategy, but there's no targeted funding for it, which I thought was kind of interesting. And then Diane Rausch emphasized the better integration of mental health as it affects HIV outcomes. And I actually think that was another whole theme throughout the conference, much more attention these days to mental health integration. The second question they addressed had to do with supporting the next generation of implementation science researchers. And, I think a lot of that information is well known. Except Jeff Garnett, who said that the Gates Foundation was supporting research groups in Africa and really emphasized the need to be much more intentional about funding local people. And then after that panel, Marlene Brass introduced a new feature of JIAS, which I just wanted to make sure everyone was aware of. It's called Field Notes. And this has just been initiated. You could find the information on the JIAS website, but the point is they're brief, focused articles that describe experiences of individuals working at the front lines of care and prevention program implementation and community engagement. And they define a specific concern, like responses to providing optimal care in ways in which task shifting can augment service delivery. That's just one example. And they discuss how a team addressed the problem and developed a unique solution that could be of interest to a broader HIV and AIDS community. So the idea of the field notes is to provide timely insights regarding contemporary challenges in HIV public health practice, including the observations about the mechanisms of change, contextual influences, and findings that emerge from implementation of evidence-based interventions and programs. So I think a lot of the work that folks are doing here, some of the HRSA funded work and the CBA projects and so on, might really lend themselves to that field notes. It's a much smaller submission as well. And so we then heard one example from Nataya Panupak, again, about this KLPHS program in Thailand and about key population-led service delivery. So I think then there was a late breaker session in track E that had a number of presentations focused on strategies to support adolescents' engagement in HIV treatment, promoting choice in the selection of PrEP methods among adolescent girls and young women, high-level discussions on national strategies for implementation and scale-up of HIV self-testing, which received a lot of attention, and HIV syphilis dual testing using rapid diagnostic tests. I won't summarize each presentation in the interest of time, but I have the details if you would like to find them, but you have the session number as well. And then there was a satellite session on leveraging implementation science to end the HIV epidemic in the United States. And this was another session in which a special supplement of a journal was introduced. This is the JADES volume on this very subject, IAS for the Ending the Epidemic Initiative. So the presenters were some of the authors of these papers, and they addressed the findings from their implementation science projects that were funded through the CFAR ARC EHE supplements, some of which some of you got. They reviewed the challenges, evidence gaps, and future directions in implementation science vis-a-vis the EHE. And then finally, track E, an abstract-driven session of interest that looked at optimizing investments for health, cash, cost, and prices. And in this session, presentations addressed the impact and effectiveness of conditional cash transfer on the HIV incidence. And that was one project in Brazil, offering broadly neutralizing antibodies, BNABs, for HIV prophylaxis to infants. That was in the US at Mass General. Looking at CAB-LA, the cabotegravir long-acting, compared to tenofovir over a 20-year time horizon, and the cost effectiveness of CAB-LA relative to oral PrEP. That was done by folks at WITS in South Africa, and then looking at variation in average unit prices of ART in low and middle income countries. That was done by a fellow from UNAIDS. Okay, how am I doing on time, Sherry? Okay. A fourth theme was around integrated services. 2 sessions of note. One was a symposium on In It Together, how to integrate health services for specific populations. And this session focused on integrating HIV prevention and care services for, firstly, people who inject drugs, secondly, transgender persons, and third, people living with non-communicable diseases, particularly in sub-Saharan Africa. So one presentation from India highlighted same-day HCV test and treatment with linkages to HIV and HBV treatment and prevention for people who inject drugs, and about the importance of streamlining these services, and how a successful model was built by scaffolding it onto existing government structures that offered free HCV treatment. And then a presentation from Thailand that looked at integrated trans-competent care for trans women and trans men, and that emphasizing the Tangerine Clinic, which many of you may have heard of in Thailand, that provides comprehensive integrated trans-centered health services that include hormone treatment and mental health services, in addition to HIV, hepatitis, and HPV prevention treatment and care services. And then in track D, in the oral abstract-driven session on integrated mental health approaches and care among people living, this is another place where mental health got significant attention. It featured presentations on the effect of mental health on HIV-related outcomes for key populations, including young women and sexual minority men living with HIV. It also examined broader barriers to mental health seeking behavior among these groups and opportunities for interventions to improve psychosocial health outcomes. So there was a presentation from a cohort of young women in South Africa who were living with HIV that found that social support attenuated the relationship they discovered between high levels of HIV-related stigma and poor retention in HIV care being associated with higher levels of suicidality. So the authors concluded that obviously the need for interventions that strengthen social support services would improve mental health and reduce this suicidality. Another study of a survey from young Black sexual minority men living with HIV in 2 US cities looked at the predictors of mental health service utilization and unmet needs, and found that homelessness, severe anxiety, and participation in non-organized religion was associated with better mental health care utilization. A third study analyzed data from the Ontario HIV cohort study and looked at the association between loneliness and antiretroviral medication adherence, and found that people with higher loneliness scores were more likely to skip medication. That probably doesn't surprise anybody. And finally, a study that compared multi-level predictors of attempted suicide among youth in New York City with perinatally acquired HIV found that factors associated with having attempted suicide were sexual minority identity, lower self-concept, negative life events, and history of incarceration. So clearly the linkages between mental health, including suicidality, and HIV are really important to pursue in a more integrated way. Next, a fifth theme was around the impact of COVID-19 on HIV services. As I mentioned, some of this was presented at the PEPFAR annual meeting, in which part of what we heard about was how the PEPFAR program was able to pivot and really help with COVID services in really some amazing ways. And then there were 2 sessions, abstract-driven sessions, one in track E and one in track D. The track E session on resilience, the new normal, included presentations that highlighted novel strategies for addressing gaps in HIV care, the care continuum resulting from the COVID-19 pandemic, including declines in HIV testing, reduced clinic visits, the need for contact tracing for COVID-19, and reduced access to HIV prevention services among key populations. So we heard a report from a project in Malawi that successfully implemented outreach with mobile health clinics to blunt declines in HIV testing rates, a project in Lesotho that trained village health workers to integrate COVID-19 screening and contact tracing into routine HIV services, data from Ireland that showed a digital online tool to promote HIV testing could circumvent gaps in access caused by the COVID lockdown regulations and could engage unreached populations and create new demand for HIV testing services. And a project in Nigeria that used social media to mobilize female sex workers, discuss risk behaviors, and increase testing there, HIV testing there. In Track D, the Pandemics Living with HIV During COVID-19 session had a number of really interesting and diverse presentations that highlighted similarities and differences between the HIV and the COVID-19 pandemics with respect to their impacts on vulnerable populations, health disparities, stigma and othering, leadership responses, social isolation. And it noted that novel interventions and methods may blunt and potentially even reverse the effect of the COVID-19 pandemic on access to HIV services. But further research was needed to demonstrate their effectiveness, including cost effectiveness and potential sustainability. So we had a presentation from a mobile web survey and focus group study with young people living in Uganda that showed, majority said they could not access services because of the lockdown. And that interestingly and troubling, young people felt double stigma if they tested positive for COVID-19. Sarah Schwartz, who some of you may know from Southern California, presented on an interview study that looked at pandemic similarities and differences among long-term survivors, long-term HIV survivors, and early AIDS activists in 8 countries, and found that similarities included stigma and othering, health disparities, slow and inconsistent government response, and crushing fear and anxiety. Key differences were related to stigma associated with disease transmission, the social shaming that was associated with HIV did not appear to be evidenced with COVID among these folks. But they had traumatic memories from the 80s and 90s that were triggered for all the participants during the shelter in place period, and many expressed anger over lessons not being learned. There was another presentation of mixed method studies among men who have sex with men in North India who reported significant reductions in access to condoms, HIV testing, and counseling services during the lockdown, and how the social distancing stress was significantly associated with depressive and anxiety symptoms. And there was more on that. And then finally, a study using that you'll see an excerpt from the visual here, using participatory visual methods to explore experiences of COVID-19 among adolescents in South Africa who were affected by HIV. And the participants said that the illustrations that were used helped visibilize and document their experiences, making them feel seen during isolation, helped them feel connected to other youth, even at a distance, and elicited positive reflections on their coping strategies during COVID-19. So the use of these kind of illustrative methods is probably something we'll see more of. Okay, next. And finally, in terms of the key themes that I wanted to mention is global health equity. 2 sessions of note here. One was a panel session, a prime session again on health equity for all. And the participants in that were Jen Cates, who most of us know from the Kaiser Family Foundation, who served as able moderator, as she always does. Ambassador Nkengasong from PEPFAR, Greg Gonzalez from Yale, former current professor AIDS activist, Fatima Hassan from the Health Justice Initiative in South Africa, Cecilia Chung from the Transgender Law Center here in San Francisco. And the key topics that were addressed during that session were re-examining the global health architecture to de-emphasize the sort of top-down and imperialist approach that has predominated the response, and to instead look at models for co-creation and bidirectionality of knowledge. And then secondly, seriously reforming intellectual property policies to make access and pricing of commodities, essential medicines, prevention technologies, and other needs more equitable. Then there was a symposium on equitable rollout of health products and what it would take to ensure that. And that session highlighted strategies, partnerships, and processes necessary for ensuring equitable access to new HIV-related products. The panelists included Esteban Buron from the Medicines Patent Pool in France, Mitchell Warren from AVAC, who many of you know, and Karen Hatzold from PSI South Africa. And Mitchell's presentation in particular on innovating access to prevention technologies specifically focused on the need to have research and development, R&D, in parallel with clinical trials, to not wait until all trial findings come out to develop product introduction and rollout strategies, but to rather already have those in place. And he reminded us that it took about 10 years for the PrEP rollout following the initial trial results, and that just wastes way too much time. Okay, next slide. I wanted to list, because again, time constraints, I couldn't cover everything. I did want to also list a few other topics that I think are of interest and just direct you to some sessions that you might want to pursue if you are personally interested in them. HIV self-testing, as I mentioned earlier, did receive a fair bit of attention, and there was a symposium and a Tracky oral abstract session wherein some interesting findings were presented. This Nigeria STAR project got some attention at the conference in particular. Secondly, HIV and armed conflict. A lot of attention to Ukraine particularly, but also other settings where armed conflict has produced significant disruptions or potentially significant disruptions mapped onto the COVID pandemic currently in the delivery of HIV-related services. And at the PEPFAR annual meeting, we heard from Yana Sazanova from Ukraine, who's a PEPFAR person in Ukraine, about the ways in which people in Ukraine were able, not just at PEPFAR, but community organizations, clinics, and elsewhere, were able to continue providing health services, HIV services, harm reduction services, in the context of PEPFAR and other programs, even while under attack from Russia. And it was a really interesting and important presentation I would encourage you to watch. There was a prime session specifically focused on HIV and armed conflict with Andrei Klepikov, also from Ukraine, who, again, very powerful presentation and emphasizing the resilience and the ways in which the people in the country have responded and continued to promote HIV and other health services under the worst circumstances, as well as others on that session. And then finally, last but not least, current concern, of course, is monkeypox and its intersection with HIV in particular. We had a special symposium on monkeypox at the conference, which of course had its necessary demonstration of people who felt the US government response was not sufficient. So that's a photo from that there. But there was also, it was a really interesting panel, most importantly, beginning with Dimi Ogoina from Nigeria, reminding folks about where monkeypox is endemic and how a new outbreak already had emerged in West and Central Africa that nobody was paying attention to, and talked about what was known from that and what the experience of monkeypox historically has been in regions where it's endemic, to lead into how it was similar and different to what is currently going on elsewhere in the world. And that session to get that information in particular. But the key points were around that experience, the slow and disjointed response from the government, particularly, but not only the US. Key questions around communications. How do we do targeted communications for populations most at risk? In our case, men who have sex with men, gay men, trans persons, and so on. Without further stigmatizing them. We're increasingly discovering that monkeypox is being disproportionately experienced by people with HIV. And so similarly, how do we not compound the stigma and discrimination? And then importantly, how communities, particularly in this case, communities of gay men, have changed their sexual behavior, which they did during COVID and now again in monkeypox to some extent in combination with vaccinations that are resulting in declining new case rates. So we need to be mindful of how communities lead sometimes in response to these pandemics. So with that, I'm going to stop and turn things over to Robert for his comments and additions, and note the fellow CAPS and DPS folks in the photo down there on the bottom who are also there, and hand it over to you, Robert, and thank you all for your attention.
Good morning. Thank you, Judy. That was a mouthful. I need to take a break after you said all of that. Rochelle, can you go back up 2 slides, please? So at the point that this presentation was being put together, Judy was very gracious and reached out and asked me to present my perspective. I cannot pretend that my perspective will be anywhere as extensive as hers on what the conference was. So I'm giving a perspective of a person who's first time attending the International AIDS Conference. I'd heard about the conference before. Durban, Washington, D.C., Amsterdam, Paris, and a few other places over the years, but had never had the opportunity to attend. My opportunity to attend this year came about as a result of a scholarship that I received from NASM, who received funding from Gilead for a cohort of Black gay men to attend the conference. And I'd like to thank both Greg, my immediate supervisor, and Mallory, who were both gracious in their permission for me to be able to attend, outside of the fact that it wasn't directly related to my work at CAPS, but could brighten my horizons and get a better understanding of what's going on in the world. And so it did. Next slide. So, I'm sorry, Rochelle, can you go back? Go back one more. So Montreal, what a great city. My dorm was a few blocks away from where the conference was being held at the convention center. And so I had the opportunity to see a little bit of the city in the morning and the afternoon on my walks to and from the conference each day. For me, Montreal has the charm of an old European city as well as a bustling metropolis. I got to see old world churches that I think would rival the churches that I've seen in Rome. And Canada, with its universal health care, allowed me to receive my first dose of Mpox. And so when Judy made the comment about the controversy in the United States and how the rollout of vaccines for Mpox is happening, I would agree wholeheartedly, because I was able to make an appointment in Canada and got my vaccine the next day without any problems whatsoever. No lines, no hassle, no nothing. So that was really great for me as well. Next slide. We can go to the next slide. So the conference was huge, bigger than anything that I'd ever seen domestically attending conferences over the years, like 5,000 people, which is bigger than anything that I've seen before. I remember the first morning walking into the plenary. I didn't know what to expect, but the room was packed, jam-packed. I was sitting all the way in the back. I hate to sit in the back of conferences, but that's where I was. And not to be outdone, protesters started at that first plenary that first morning, which got me really excited because I was like, oh, wow, they are showing out. There were protests every day, and I commend all of the protesters for putting their points of view out there, because I wholeheartedly agree that I'm an activist at heart, and I love to see that activism going on at the conference. So I just loved it. There was lots of talk about equity and inclusion and community-centered approaches. And so I agree with those. Those were some of the themes that resonated with me about what was going on at the conference. So when Judy was doing her presentation and she was saying some of the stuff about community and stigma and inclusion, all of those things resonated with me as well. The other thing that I will point out is that there was a clear judgment about the Canadian government for not having any representation at the conference. Folks were highly upset about that, and it was mentioned at most of the plenaries that I attended. Every time that folks got up, they were like, where's the Canadian government? They should have a representative here, and I wholeheartedly would agree with that. Next slide. The International AIDS Society had leadership change during the conference, so I thought that was quite interesting as well. I went to one of the business meetings where they actually handed off to the new president, Sharon Lewin, and that was a whole presentation within itself. They actually allowed people in the room to vote on issues, like they presented their audit, and the room voted on the audit there, which I thought was quite interesting. I was like, if I had a society like the International AIDS Society, I certainly wouldn't go to the conference and allow people in the conference to vote on whether or not we approve the audit or not. But it was quite interesting. I could see it as an opportunity for activists to act up. And quite frankly, I was crossing my fingers and hoping that something would happen there, but it didn't. Next slide. Some of the interesting sessions that I attended were on long-acting injectables for HIV and PrEP for prevention. But I must admit, the presentations were highly academic and very formal, and they went way over my head. So I was like, woo, that's a lot to get in one bite. couldn't digest it. The Global Village was really fun. I spent a lot of time there during the conference because there were workshops going on and was much more of an opportunity to meet people from all over the world. My goodness, there were so many people from Africa there. I felt like I was at home. The exhibit hall for me was a little bit disappointing because I've gone to conferences before where the exhibit hall has been much more interesting. Their exhibit hall, they didn't give out any prizes or any gifts or takeaways, so I didn't bring anything back, but that was a little disappointing as well. Next slide. One of the, I'll say, best presentations that I went to was the launch of the 2022 American Journal of Public Health special issue on addressing HIV-related intersectional stigma and discrimination. And Judy mentioned a little bit about this. And my take homes from this particular presentation were that first, there were some people who were up on the stage presenting that I knew. I mean, I imagine this big conference, not many of the people that were presenting during the course of the days that I was there did I know. But in this presentation, Daniel Driffen from Atlanta presented, and Tanya Potet, who's a visiting professor from the University of North Carolina, they both presented. And they talked about presentations or research being community-centered and including people who are the object of the research that's being done, and I wholeheartedly agree with that. Those are my takeaways from the International AIDS Conference 2022. I had a really good time, and yeah, I would go back to Montreal again. Thank you.
So clearly, Robert got out a lot more nice.
Well, no, you got a lot more out of the presentations than I did. I got a lot out of going to the conference and just being present.
It's great. It's really always great to hear a perspective of someone who hasn't been to these before, because they get a little bit formulaic for many of us who have, including the demonstrations, which are highly performative at this point, but you know, they're still super important. So it's great to get your firsthand experience.
Yeah, I wanted to open up the opportunity to send a question to the chat or to raise your hand if you have any questions for our speakers, or if you were at the conference and there's something you really wanted to make sure we all knew about. For those of us who weren't there, anything that you saw that was super interesting, different, other points of view.
Perhaps while we're waiting, Sherry, if you see a hand, I put in the chat, but a big controversy and what Robert was referring to about the call for a high-level, top-level Canadian government representation at the conference that was notably absent had to do with the fact, you probably all heard about this, that a number of people, particularly from African countries, but not solely, were not able to get their visas for which they had applied months in advance, because of a massive backlog in the Canadian screening system. It's unclear entirely what was responsible for it, but the gist of it was loads of people, including very high-level people, either almost didn't get them approved or didn't get them approved and couldn't come to the conference. And it was just appalling, and people were really upset about it. So that was a big part of the aura at the conference from the beginning. And it appeared racist because it was predominantly people from Africa who were not given the visa entry.
Yeah.
The entry visa.
Thanks for pointing that out. I also wanted to just let folks know, for those of you who haven't seen the AJPH special issue on intersectionality that both Robert and Judy mentioned, there's about 6 authors from UCSF, that contributed to that special issue, which is really exciting, and a whole bunch of others who are VPs in the VP program over the years. As Robert mentioned one, but also Lisa Boleg, there's been a couple. So that was an exciting publication if folks want to check it out. Yeah. Well, I guess, one of the things I did want to check in about, and I know, Judy, you said that you didn't follow all the long-acting injectable discussions very closely. And I know, Robert, you said you did see 1 or 2 sessions on that, but I am curious with whether there was any discussion at some of the PEPFAR meetings or other meetings about the cost of the long-acting injectables, and whether there's any progress being made about pushing that forward, both for PrEP and treatment. If either of you are.
Yeah, I mean, Robert, if you don't mind, I'll just jump in fast. The gist of the conversation now is not the efficacy, it's really the effectiveness, because that's so much related to uptake, availability and uptake around the world, and sort of equitable uptake of long-acting injectables, both for treatment and for prevention. And I think a lot of the conversation now is, in fact, about the issues of cost. But also there was a lot of attention to, and there is a lot of attention in literature now about what is required to actually administer long-acting injectable formulations at a clinic setting, and the training of the persons doing providing the interventions and the infrastructure and that's needed, plus insurance cost, everything else. So folks seem to now be very focused on the obstacles to implementation of long-acting injectable and how that will affect how much uptake there actually will be. And does it even affect desirability amongst people who would be otherwise inclined? So I don't think anything has resulted from that. I think people are working on schemes for how to lower costs, particularly in high burden countries and settings where the population who might be most interested in using for treatment or prevention. But I don't have details on any negotiations or anything.
Yeah. What's interesting about that is that if the barriers are, workforce issues, like we've seen this before. I mean, it used to be that you had to be an MD to provide, art to HIV treatment. And now, the task shifted. Now you can be a nurse, even like, in some countries, sort of a nurse assistant to initiate someone on ART. And here we are again dealing with, who's in power, who can decide who gets to put that injection into somebody's arm. So it's interesting.
Yeah, it's also always challenged us to think about how we get stuck in a box of who is an appropriate administrator of something, who's appropriately trained. I'll just give you a funny anecdote that happened in another conversation around monkeypox, independent of this conference, in which one participant said, hey, when the CDC determined that they would divide up the doses and have them administered subdermally instead of intravenously, people were saying, oh, well, this is technically very difficult to administer. You have to get the needle in just right, just under the skin, and get the blip and all that kind of stuff. This person said, I know who can do that, tattoo artists. And people were like, ah. And I thought, well, hold up, this might not be such a bad idea.
Yeah.
So I think the ability to think outside some of these really kind of guild focused, structured, professionalized ways of thinking about things, to really being open-minded to how we can engage all manner of people.
Yeah.
It is really limiting things.
It's a great point. Robert, I wanted to make sure you had a chance to respond to the long-acting injectable question if you want to.
No, I don't want to respond to that particular question, but I think it is a good question. I think that it should be available around the world at a cheaper price. So cost is always an issue. That was one of the other things that I thought about when I was speaking, or didn't say, is about the inequality of the richer countries and the poorer countries. And there definitely was a tension at the conference for folks who have money and those folks who don't have money, and how that works itself out in the whole world. So something needs to be done about that. And so, as an activist, thinking that changes need to happen, and I'm not sure where they happen or how they happen, but I wish a change would come.
Yeah, thank you for saying that, because that's why I wanted to emphasize the health equity sessions. It may not have been like an obvious theme to other people, but I think it's at the crux of everything we're thinking about and doing, and was so heightened during COVID and now monkeypox again. Not like we didn't learn it with HIV and everything else that's come before it, but yeah.
Yeah, well, I don't see any other questions. I did want to just, Judy, if you could just remind folks about the CROI call for abstracts and behavioral science. This would be a great opportunity just to make sure everyone knows about that.
Great, thanks for suggesting that, Sherry. So as a result of some hardcore advocacy by a number of us in the social and behavioral sciences and a couple of allies, we have managed to, we think, influence the Conference on Retroviruses and Opportunistic Infections, CROI, which you all know historically has not been friendly to our sciences, to actually include us in the 2023 program. And they're doing a little bit of baby steps. And I can, regale about how this came about some other time, but the gist of it is we are seeing this operationalized in the abstract submission call and categories where the organizers accepted some of the suggested language from our group, not all of it, and not perfectly, but there is now very concrete invitation and specific areas of research that our sciences are relevant to. So we really we need to make sure that people submit abstracts. They may not be accepted, 90% of them, if they are, will be in posters. That's just the way CROI is. But to have more behavioral, social, and implementation science on the CROI agenda as indicative of the excellent science for which that conference, markets itself as the top science meeting in the world on HIV and associated infectious diseases. It's very important. So please submit, please share the information. If you didn't see it directly or need the link, let Sherry or me know, and we'll be happy to send it and share it with you. But it's a huge development. It's really the first time. So those, unfortunately, the abstracts are due soon, September 20th, I believe, if they're HIV. If they're on monkeypox and other things, there's a different deadline, or COVID. But for HIV-associated research, so just if you have any rigorous research that hasn't yet been presented, please keep CROI in mind and submit an abstract.
Thank you, Judy. All right, well, it's 2 minutes before the end of the hour. Unless anyone has a burning question, I think we might just thank our speakers. Thank you so much for the tour de force on telling us what was going on both inside the conference rooms in the symposia and outside of the conference symposia and abstract different sessions. It's really great to get an update. And I'm sorry we weren't all there, but maybe, at the next IAS conference, we'll have even more folks that can attend and let us know how it goes. And I also wanted folks to be aware that AIDS Impact abstracts are going to be opening soon as well. That's a social behavioral conference specifically, so that's always a good place to send your work.